fortunate today to also have Dr. Jrowe Chen. She's an associate professor of medicine at the University of California, San Francisco, in the Department of Hematology and Oncology. She's a medical breast oncologist at the Helen Diller Family Comprehensive Cancer Center. Her research is focused on the clinical development of novel strategies and targeted therapies for patients with metastatic and early-stage breast cancer. She's particularly interested in the unique needs of young women diagnosed with breast cancer, including the impact of breast cancer treatment on fertility. She's a graduate of Harvard Medical School, completed her residency at Massachusetts General Hospital, and her fellowship at UCSF. And we're so fortunate to have her here today, so thank you so much.
Thank you.
It should be working. Is it not working?
Oh, that's okay.
Okay. All right. And then I guess that's the microphone, or if you want to move around, we can turn that one on. Okay, thank you.
Move around. Hi, good morning, everybody. Thank you so much for inviting me to speak. I'm really thrilled to be here. This is my first interaction with YSC, and I hope it's not my last. So I'm going to spend the next hour talking about endocrine therapy in premenopausal women in the adjuvant setting, so not the metastatic setting. The objectives are to review the current, current standard treatments in premenopausal women based on standard guidelines and current clinical data. I'll go over the soft and text results that were published a couple years ago and the updated current algorithm for how to approach endocrine therapy in premenopausal women. We'll talk a little bit about extended hormone therapy, meaning beyond 5 years, and who we should consider for that. We'll talk about a few of the major side effects related to endocrine therapy and talk about a couple new presentations at San Antonio addressing a couple common side effects like vaginal dryness and joint pains. And then ongoing adjuvant trials looking at endocrine therapy targeting resistance mechanisms. Okay, so as you know, breast cancer is the most frequent cancer. And I'm going to move this. Sorry, I can't. I will use this. Can you hear me? Okay. Okay, that's better. Still? Nothing? No, okay. So breast cancer is the most frequent cancer in women worldwide between the ages of 15 and 39. It's a leading cause of cancer death in women 45 to 55. In the United States, in women under the age of 45, it makes up about 11% of all breast cancer diagnoses, and that's approximately 25,000 cases a year. Although ER-positive cancers make up about 70 to 75% of breast cancers in general, in patients under 50, it's about 60%. There's a higher incidence of triple-negative breast cancers in younger women, so that's why the percentage is a little bit lower. So the first description of endocrine therapy in breast cancer was actually described in 1896 by a British surgeon. And he published 3 case reports describing, you can read, it seems that the evidence of the ovaries and testicles having control in the human body over local proliferation of the epithelium. And he noticed when he removed the ovaries that patients' breast cancers regressed. And this was before the discovery of both estrogen and estrogen receptor, which didn't happen until mid-1900s. This is a caricature of a breast cancer cell. So estrogen receptor, you can think about, is the first target in breast cancer, discovered in 1958. So estrogen binds to the estrogen receptor. The estrogen receptor is a nuclear receptor. It's in a family of nuclear receptors, which includes progesterone. And what happens is once estrogen binds the estrogen receptor, it translocates into the nucleus and binds to elements on the DNA, which leads to transcription of multiple genes responsible for proliferation, survival, and metastases of breast cancer. So as you'll hear some of today, multiple drugs have been developed targeting the different pathways, not only in the estrogen receptor signaling pathway, but you'll see in HER2, IGF-1R, and then downstream molecules like PI3 kinase, AKT, which lead to the activation of the estrogen receptor and transcription. All of these molecules are being looked at and targeted as potential therapies in breast cancer. What are the goals of endocrine therapy? The goal is to prevent estrogen from stimulating the growth of cancer cells. What are the strategies to do that? At least for now, the current therapeutic strategies include one, blocking estrogen activity, that would be tamoxifen. Blocking estrogen production, there's a few strategies to do that. One is through an aromatase inhibitor, which prevents estrogen production. Ovarian suppression, where we're inhibiting endogenous estrogen production through the ovary, and surgical oophorectomy. Fulvestrant downregulates the estrogen receptor. That is not an approved regimen in the adjuvant setting. It is in the metastatic setting. We won't be talking about it today, but I included it so you know that the broad range of treatments targeting these pathways. So let's start with tamoxifen. You can think of tamoxifen as the first targeted therapy in breast cancer. And you can argue it still is the best targeted therapy in breast cancer, although Herceptin is pretty good too. So tamoxifen is a selective estrogen receptor modulator. What that means is that it inhibits the estrogen receptor. It is an antagonistic competitive binding molecule. The interesting thing is, though, it actually activates other organs. So it's an inhibitor on the breast cell, but it can be an activator on the uterine cell, bone cell, and even in the brain. So it was initially FDA approved in the metastatic setting in 1978. It then gained approval in 1986 for node-positive early breast cancer, and then in 1990 for node-negative early breast cancer. So these are data from a meta-analysis put out by the Early Breast Cancer Trial List group. They update these data every 5 to 10 years or so, and these are data only in women under 45 looking at the benefit of tamoxifen, and these include over 30,000 women, and this is just 2,000 under 45. And what they found is with 5 years of tamoxifen, there's a significant benefit not only in breast cancer mortality, which is the panel on the left, but overall survival, which is the panel on the right. So with 5 years of tamoxifen, you can see that that benefit continues through 15 years. And at 15 years, patients who did not receive tamoxifen had about a 36% chance of dying from breast cancer, and those who had 5 years of tamoxifen had a 25% chance. So about a 10% absolute gain due to 5 years of tamoxifen. And that similar gain was seen in overall survival as well. What are the side effects? These data come from a prevention study looking at high-risk women, and it was compared to placebo. So most common side effect, hot flashes. So 80% of women will describe hot flashes to some extent. 30% will say that they're severe. Associated with those hot flashes include cold sweats and night sweats, vaginal discharge, which is benign. It's a clear, non-bloody discharge. It's a nuisance and not dangerous. There's a couple studies describing sexual dysfunction, but the data are mixed in terms of decreased libido, vaginal dryness. And there's a couple rare but serious adverse events. The first is an increased risk of thromboembolic events like DVTs and PEs. The absolute risk is still low. So in the placebo arm, the risk was about 2.4%, and in the patients who received tamoxifen, it was 4.1. So it's a small but statistically significant increased risk of blood clots. The second rare but important side effect is the increased risk of uterine cancer. It's not just uterine cancer. You can have abnormal vaginal bleeding due to the thickening of the uterine wall. So remember I said the tamoxifen can stimulate uterine cells. So you can get thickening of the uterine lining, abnormal vaginal bleeding. So all of these patients should be followed by a gynecologist in the event that they have abnormal vaginal bleeding. The risk of that, though, is still incredibly small. In the placebo arm, it was 0.3%, and in the tamoxifen arm, it was 0.8%, but the relative risk was 3.28. Some side effects that our patients will report, but have not been shown to be directly due to tamoxifen, include weight gain. So in these studies, there was no difference in weight gain between placebo and tamoxifen, but the majority of our patients will report weight gain. There's a lot going on during a diagnosis of breast cancer. Many of our treatments induce menopause, which we know slows metabolism, changes the distribution of fat. So there's a variety of reasons for it, but in this study, there was no difference. Same for depression, anxiety, major psychosocial outcomes, and overall quality of life. Let's move on to ovarian suppression. And I think what's helpful when we talk about ovarian suppression and aromatase inhibitors is to review the normal physiology. Okay, so the hypothalamus and the pituitary, the hypothalamus controls the pituitary through GnRH and signals the pituitary to send out LH and FSH to signal the ovary. The T and the G, these are theca and granulosa cells of the ovaries, to make testosterone and estrogen. So all of estrogen is produced from testosterone, okay? And aromatase is the enzyme responsible for the conversion of testosterone to estrogen. Similarly, the adrenal gland gets signaled to make androstenedione, which is a testosterone. And in the peripheral tissues, the fat, the muscle, bone, liver, breast tissue, normal breast tissue, tumor, there's aromatase that converts testosterone to estrogen. So in a premenopausal woman, you have most of your estrogen being produced in the ovary, but you also have estrogen being produced peripherally. Okay, so drugs like Zoladex, Lupron, these are either GnRH analogs or LHRH agonists that essentially inhibits the pituitary from being able to stimulate the ovary to produce estrogen. Okay, so drugs like Zoladex and Lupron are what we consider ovarian suppression medications. We'll talk about aromatase inhibitors as well. Aromatase inhibitors inhibit aromatase, and in a premenopausal woman, you are not able to fully inhibit the conversion of testosterone to estrogen in the ovary. It's just too robust, right? In a postmenopausal woman, the ovaries are no longer making estrogen. So all you need to do is inhibit the aromatase in the peripheral tissues, and we can do that successfully. So in a postmenopausal woman, you're completely depleting estrogen. In a premenopausal woman, you have to inhibit the ovary. You need to use Zoladex and Lupron to inhibit the ovaries, to suppress the ovaries so it doesn't make estrogen on its own, and then you rely on aromatase inhibitors to inhibit the peripheral estrogen in premenopausal women. So I think that's, a lot of people don't understand that, and it's worth clarifying. So what are the data for using ovarian suppression in premenopausal women? So these are data before the soft and text data, and it comes from retrospective analyses. So these data come from a study of all women, pre- and postmenopausal women, who got chemo, that's the CAF, who got chemo plus Zoladex, or chemo plus Zoladex and tamoxifen. And when you looked at the entire study population, there was no difference between the three arms, really. But if you looked at the patients who were under 40, you can see that there was a benefit in terms of disease-free survival with the use of Zoladex, and furthermore with Zoladex and tamoxifen. So why would it be that you don't see it in the overall population, but you see it in women under 40? Well, the thought was that these patients all got chemo. The women who were older, the chemo put them into menopause. But for the women who were really young, under 40, they still had residual ovarian reserve after a full course of chemo. So they needed the additional ovarian suppression in order, and if they got it, they benefited. So this was probably the best retrospective data that led people to ask the question, would it be better for a premenopausal woman to get ovarian suppression, and then if we gave them ovarian suppression, then we can also give them an aromatase inhibitor. These are meta-analyses data basically showing the same thing. So they looked at a number of studies of women under 40 who got chemo plus or minus ovarian suppression. And again, you can look at the hazard ratios. The hazard ratios are lowest for women who are under 40 and then little or no benefit in women over 40. Okay, moving on to aromatase inhibitors. I think we already discussed most of this. It's responsible for the last stage of estrogen production. We are able to suppress more than 96% of aromatase activity, and we cannot give it to a premenopausal woman unless we induce medical or surgical menopause. And the reason is, remember, if we don't induce, if the woman still has any ovarian reserve, what happens is when you give them, and I'll go back to this diagram, when you give them an aromatase inhibitor, what actually happens is you are transiently decreasing the peripheral estrogen, and then there's this negative feedback where then it's signaling the pituitary to actually signal for more estrogen to be produced. So in these premenopausal women, if they are inappropriately on aromatase inhibitor without ovarian suppression, you can actually increase the estrogen levels, and that's paradoxical to what we're trying to do. So we always, if there's any question, and I think most of my colleagues, will check estradiol levels in these premenopausal women to make sure that they are fully suppressed. We know in a postmenopausal woman that aromatase inhibitors are superior to tamoxifen. A number of dozens of studies have looked at this in a variety of settings, and AIs are superior by about 3 to 4% out at 10 years in both improving disease-free survival as well as survival in some studies. So that leads us, let's talk about the side effects of aromatase inhibitors. Okay, and I will preface this by saying oftentimes clinical trial toxicity data does not necessarily mirror what we are seeing in the clinic. For some reason, sometimes it looks better than what we see in the clinic. So in this study that compared aromatase inhibitors to tamoxifen, there was a small increased risk of arthralgias or joint pains. However, about 30%, 35 versus 29, reported joint aches. And I would say it's much higher in our clinic, especially with aromatase inhibitors. I would say at least 60%, if not more. And the difference between the two groups here is only about 6-7%, and I would say that is definitely an underestimate of what we're seeing in the clinic. And other things to mention, so fracture rates. So because we are depleting estrogen in these patients, and we know estrogen is a stimulator of a bone cell and protects the bone, aromatase inhibitors that's depleting estrogen is going to put patients at risk of accelerated bone loss and increased fracture. So in fact, there is a slightly higher risk of fracture, 11% versus 7.7% with an aromatase inhibitor. The good things with aromatase inhibitors is that there is no impact on the uterus. It doesn't cause abnormal vaginal bleeding. It doesn't increase the risk of uterine cancer. Also, there is no increased risk of blood clots. A lot of our surgeons will take patients off aromatase inhibitors around surgery because I think sometimes there's confusion with tamoxifen, but there's no increased risk with aromatase inhibitors. Okay, so we've discussed that tamoxifen is a really good drug. It's beneficial out to 15 years. There was data supporting ovarian suppression as well in premenopausal women, but we had no prospective data until recently. I've shown you that in a postmenopausal woman, AIs are superior to tamoxifen. So of course, the million-dollar question was, is ovarian suppression in AI superior to tamoxifen alone in a premenopausal woman? And this was a really important question, and really until we had the soft text results, we were giving patients tamoxifen alone. I think anecdotally we would give patients ovarian suppression with that because of the rationale for it, but we would do it with tamoxifen. We didn't necessarily switch them to an aromatase inhibitor without the data. So the data were published, one paper in July of 2014 and a second in January 2015 in the New England Journal, publishing the results of the soft text data. So what are the soft text trials? So these are two trials trying to ask the same question. The text trial, so both were premenopausal women. They had to be randomized less than or equal to 12 weeks from surgery. If they did not get chemo, if they got chemo, they had to be randomized within 8 months after chemo, and they had to be premenopausal within 8 months after chemo. So either they had to have their periods return, actually I think their periods had to return in order for them to be eligible. So patients in this text trial were randomized to tamoxifen and ovarian suppression for 5 years versus exemestane, which is an aromatase inhibitor, plus ovarian suppression for 5 years. They enrolled 2,600 patients. In the soft trial, over 3,000 patients randomized to tamoxifen for 5 years, tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. And the way that, and you can see in text, there was no tamoxifen, only arm. Okay, so the way these data were presented, and the reason it was two papers, so the first paper compared the tamoxifen and ovarian suppression with the aromatase inhibitor and ovarian suppression, and combined the data from the two trials. Okay, and then the second paper was the one that compared it with tamoxifen. I'll skip this slide. So here are the data looking at the overall population. Okay, E is exemestane, T is tamoxifen, OFS is ovarian function suppression. So in the overall population, there was a benefit to ovarian suppression with aromatase inhibitor over tamoxifen and ovarian suppression. The difference was about 4% in disease-free survival. When you look at tamoxifen and ovarian suppression versus tamoxifen, there was a benefit with ovarian suppression, and then an even greater benefit with exemestane and ovarian suppression over tamoxifen. Okay, so both studies are showing benefit of ovarian suppression with exemestane over tamoxifen. Now, they went back and looked at different disease groups, and they looked at patients who had low-risk disease, meaning patients who did not get chemotherapy. So if you're a premenopausal woman and you're not getting chemotherapy, you probably have other clinical features that are lower risk, smaller tumors, negative. These studies did not dictate whether or not you got chemo or not. That decision was made by the treating provider. And if you look at only patients who didn't get chemo, there was no difference between tamoxifen arm, tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. There was no difference in terms of breast cancer-free interval and distant recurrence-free interval. So breast cancer-free interval includes cancers in the opposite breast or local recurrence. Distant recurrence is a metastatic recurrence. And if you look at the figures on the right, the lines completely overlap. So the take-home here was that for low-risk patients, there was no additional benefit with ovarian suppression, and certainly not with ovarian suppression and aromatase inhibitor. And these patients did pretty well. So if you look at all of the, if you look at the breast cancer-free interval at 5 years, about 95 to 97% were disease-free at 5 years. So that's really good. So that means our providers are doing a good job choosing patients who need and don't need chemotherapy. And tamoxifen alone is pretty good. Now, We know that ER-positive cancers can have late recurrences, so these data are still premature from that standpoint, but still these patients at 5 years are doing very well with tamoxifen alone. So now let's look at patients who did get chemotherapy. So remember, premenopausal women who got chemotherapy based on the judgment of their treating physician. So these are going to be patients with higher risk features, bigger tumors, node positive, high grade. And you can see that there's now a separation of the curves. So this study was really looking at, it was powered to look at the benefit with ovarian suppression primarily, and less so comparing the exemestane and tamoxifen with ovarian suppression. But nevertheless, you can see that the patients who got exemestane and ovarian suppression did the best. So at 5 years, the disease-free, or the percentage of patients without breast cancer was 85.7 with the AI and ovarian suppression, 82.5 with tamoxifen and ovarian suppression, and then 78% with tamoxifen alone. So that trend was also seen in terms of the distant recurrence-free interval. So the take-home message here is that patients who have high-risk features, that was enough for their provider to recommend chemotherapy, also benefited from aggressive hormone therapy with ovarian suppression and exemestane. The greatest benefit was in women under 35 years of age. Now there's huge overlap here because 94% of women under the age of 35 also received chemotherapy. So you can see the curve with aromatase inhibitor and ovarian suppression, and the difference actually between that arm and the tamoxifen only was quite high, 83.4% versus 67.7%. So like 15, 16% difference in breast cancer-free interval in women under 35. So the take-home here is, in terms of the soft text data, high-risk patients who are getting chemotherapy should probably also get aggressive hormone therapy. Women under 35 probably are also getting chemotherapy anyways, but even without chemotherapy, I think there's strong rationale for giving them aggressive hormone therapy based on this data. What is the cost of treatment in terms of toxicity? So in the SOFT study, 15% of patients stopped ovarian suppression by 2 years and 22% by 3 years. We know that adherence is an issue in all patients in terms of hormone therapy. In terms of provider-reported side effects that were clinically important, and this is interesting, 50% of providers reported depression in their patients in all groups, whether they were getting tamoxifen or ovarian suppression. 4% were severe, and there was a 5% increase with the addition of ovarian suppression. In addition, there was increased menopausal symptoms, osteoporosis, and insomnia, which is not surprising. In terms of patient-reported outcomes, looking at 85% of the trial population, there was no difference actually in the patient-reported global quality of life. And it's amazing to me that there isn't, given the difference in side effects seen between the three groups. Another thing worth noting is that the side effects are less pronounced after 2 years. Could this be because they were less adherent and compliant, or are they adjusting to the side effects? The side effects were overall less intense in women with prior chemotherapy. A lot of times the chemotherapy will put patients into menopause, and so the hot flashes start with chemo, and actually when you start the hormone therapy, you don't see as big of a difference. There was more sexual dysfunction, vaginal dryness, joint pain, bone pain with aromatase inhibitors and ovarian suppression, and then more hot flashes, night sweats, and vaginal discharge with tamoxifen. And this is a quote that alludes to what I mentioned before, which is, do we really know the true cost? Because a lot of times these patient-reported outcomes in trials or provider-reported outcomes in trials don't necessarily reflect what we're seeing in the clinic, and these side effects can be well hidden in women who are very active and professional in the clinical trial data. So the algorithm for how we think about hormone receptor positive disease in a premenopausal woman is evolving, but I would say the current state is this. So if a woman has low risk disease, small tumors, node negative, grade 1 or 2, or older, in the mid 40s to mid 40s to early 50s, and they're not getting chemotherapy, 5 years of tamoxifen is adequate. Okay? And then the question becomes, do they need more than 5 years? And we'll talk about that briefly. If patients have high-risk features, meaning larger tumors, node positive, high grade, and they're really young, like under 35, they should get chemotherapy, and then after chemotherapy, they should get ovarian suppression with an aromatase inhibitor. From our standpoint, all 3 aromatase inhibitors are the same. Whichever one you want to start is fine. Oftentimes, we switch patients from one to the other for side effects, but you can start any of the 3. Intermediate risk patients, meaning, say they have discordant features. They are low grade but slightly larger tumor, or low grade and node positive. Well, we still don't really know what to do with these patients. I think it's still reasonable to give them chemotherapy, and if you do, then you should give them the ovarian suppression. Or, there's reason to believe that these are endocrine sensitive tumors and won't benefit from chemo, and then just do the aggressive hormone therapy. But we don't really know what to do with these intermediate risk tumors, and I think part of it depends on how we approach their chemotherapy plan. So let's move on to, is longer better? For hormone receptor positive breast cancer, over 50% of the recurrences occur after 5 years. So at 5 years, and then these again are data from the EBCTG meta-analysis. And at 5 years, with 5 years of tamoxifen or hormone therapy, the risk of recurrence is 15% versus 26.5% without tamoxifen. And if you go out to 15 years, that risk is 45% and 33%. So half the recurrences will occur after 5 years. So we know that in ER-positive disease, a subset of women will have late recurrences. The million-dollar question is, who are these women? And can we predict who these patients are? That's an active area of research, which we're not going to talk about that today, but there's a number of molecular assays that are trying to elucidate that answer. So these are data from another meta-analysis that includes 46,000 women through 91 trials who received 5 years of endocrine therapy for early breast cancer. And they looked at the risk of distant recurrence between years 5 and 20. And for a T1 tumor, that risk is 14%. And a T2 tumor, so stage 2, is 21%, and higher for bigger cancers and more nodes positive. So looking at a patient's clinical pathologic characteristics can help us identify who is at higher risk of developing a late recurrence, but it doesn't tell the whole story. But it is sort of a poor man's way of predicting. So the question is there benefit to extending hormone therapy to prevent these distant recurrences if we were able to predict who those patients were? Of course we would, but we can't right now. So should we be recommending this to all patients, or who should we be recommending it to? So there have been a couple studies. I'm just going to show you data from one atlas, which asked the question, is 10 years of tamoxifen better than 5 years of tamoxifen? Okay, and on the left panel, looking at recurrence, and then the right panel is breast cancer mortality.
And it found that patients who received 10 years of tamoxifen did have a small benefit on the order of about 3%, 3.5% reduction in risk of recurrence, and about a less than 2.8% reduction in breast cancer mortality. So there is a small benefit to extending the tamoxifen, but at what cost? There was also a small increased risk of endometrial cancers. So as we've known, the risk of endometrial cancer also increases with age. So does the risk of thromboembolic disease. So in this study, they found an increase of 2% in endometrial cancers. So there's about a 2 to 3% risk of endometrial cancer with just the first 5 years of tamoxifen. And then there was an additional 2% increased risk with 10 years. So the relative risk was about 1.74. There was a small increase in pulmonary embolisms, but that difference was less significant. So that 2% in endometrial risk and a 2% risk in breast cancer recurrence is something that you need to weigh with the patient. In this trial, about 19% of patients were under 45. In the other trial called ADAM, they did not report how many were under 45. So, this is a problem. We're doing research in premenopausal women. There aren't a lot of studies only looking at premenopausal women, and even some of these bigger studies, they're not reporting the percentage of patients that are premenopausal. I would say that this situation, where we're looking at 10 years versus 5 in a premenopausal woman, is not that common. It certainly happens, but it's not that common because what that means is that patient was really young at the time of diagnosis. And if they were really young at the time of diagnosis, they probably got chemo and then 5 years of tamoxifen. So whether or not to continue another 5 years means that they're still premenopausal after 5 years of tamoxifen. We certainly have those patients, but it's not a large population. But if you do have those patients, continuing out for another 5 years is reasonable, but you would have to have the discussion about the increased risk of uterine abnormalities. So what about 5 years of tamoxifen and then 5 years of an aromatase inhibitor? So many of these women who were premenopausal at the time of diagnosis got chemo, got 5 years of an AI, now are postmenopausal, right? Should they be continued on another 5 years of an aromatase inhibitor? So this study, the MA17 study, went back and looked at the subset that were just premenopausal at the time of diagnosis. And for those patients, the benefit of another 5 years of an aromatase inhibitor were much larger than even the overall population. There was a benefit in the overall population on the order of about 3 to 4%. But in the premenopausal subset, that difference was about 10 to 11%. And that benefit was seen both in node-negative and node-positive patients. So I think these data do support the use of extended hormone therapy in premenopausal women, but the side effects and the additional risks need to be discussed. Okay, so I'm going to shift gears a little bit and talk about a couple side effects that are common and can be quite debilitating in women on hormone therapy. And we talked about a number of side effects. I'm going to focus the next few slides on joint and muscle pain due to aromatase inhibitors and some slides on vaginal dryness. So these data were just presented at San Antonio in 2016, and that's why I'm presenting them here in case many have not seen the data. These were not just in premenopausal women, but I think that these are applicable to premenopausal women. Up until this study, there were only a couple interventions that have been proven through clinical trials to be able to reduce arthralgias. One was exercise. We know that 150 minutes of aerobic exercise and 2 days a week of strength training can reduce AI-associated pain by about 30%. And the other is acupuncture. So those were the two things, despite a number of other efforts and what other things on the internet. Those are the two things that are data-driven.
So duloxetine, which is also Cymbalta, was studied for the same reason. So duloxetine is a serotonin norepinephrine reuptake inhibitor, SNRI. It's approved for a number of pain syndromes as well as depression, I believe. The investigators had done a previous study, which was a single-arm phase 2 study looking at duloxetine for AI-associated pain and demonstrated a 61% improvement in pain. So these investigators embarked on a randomized study of duloxetine or placebo and enrolled almost 300 patients and treated them for 13 weeks. Patients were stratified based on their baseline level of pain and whether or not they received a prior taxane, which we also know can cause arthralgias. These patients were postmenopausal. They include early stage breast cancer, stage 1 to 3. They had to have been taking AIs for at least 3 weeks and up to 3 years. They had to have baseline pain, and they could not have a contraindication to duloxetine for other reasons. And here are the efficacy data. The red line is duloxetine, and the blue line is placebo, and you can see, interestingly, that there was a benefit in both arms. So there was definitely a placebo effect here. But the effect was greater in the duloxetine group. And once they stopped the treatment at 12 or 13 weeks, the improvement dissipated and it converged. Okay, so what about local hormone exposure for vaginal dryness? A lot of women, I would say almost all of my patients report some degree of vaginal dryness. And we don't have great therapies. Of course, we recommend lubricants and non-hormonal interventions like coconut oil or vitamin E. I think they work to varying degrees of success. And there's a lot of interest in whether or not local estrogen or testosterone therapy is not only safe but effective. So bottom line is we don't have a lot of safety data in the breast cancer population. The reason is we don't have the numbers and we don't have the follow-up. There have been some small retrospective studies looking at this. They did not show any increased risk of breast cancer recurrence or mortality, but there were very few events, included both hormone receptor positive and negative tumors. They included both tamoxifen and AI-treated cohorts. So one study that we did at UCSF, Michelle Malisko was the study PI, was looking at vaginal testosterone cream versus estradiol vaginal ring, the E-string ring, for vaginal dryness and decreased libido in patients on aromatase inhibitors. So again, these were postmenopausal women on aromatase inhibitors, but I think that the results are applicable. So what she did in this study was measure blood levels of estradiol to see is there any systemic absorption. And the interesting thing, though, one of the interesting things that she found was that look at the baseline level under both groups, but the vaginal ring on the right and panel B. Many of these patients who were postmenopausal had estradiol levels that were quite high. And many of these are, many of these patients are 60, 70, or prior oophorectomy. So there's something else going on. So this could either be peripheral aromatization. Remember, there's some degree of estrogen being produced in the peripheral fat. Could patients be using herbs and other synthetic supplements that have some estrogen in them? We don't know, but it's an issue. But at week 4, week 12, you can see that there's no significant increase in systemic estradiol levels. And so this was a small study. 69 patients completed a 12 weeks of treatment. So we don't have follow-up in terms of recurrence, but in terms of estrogen absorption and detection in the blood, this study is reassuring that we are not seeing increases in estradiol levels. These patients report a very nice
benefit in terms of vaginal atrophy. They all underwent GYN speculum exams, so the mucosa improved and their symptoms improved, most importantly. So in our clinic, I don't hesitate to try the E-string ring. It's a ring that patients or their GYN can insert once every 3 months, and I can say most of my patients love it and say that they noticed a difference quite immediately. So what about patients who are at extremely high risk? Are there trials for these patients, and what are we doing for them? You've probably heard or you know of palbociclib, also known as Ibrance. So this is a CDK4/6 inhibitor. It inhibits cell cycle division. It is approved in the metastatic setting based on a phase 3 trial for first-line hormone receptor positive metastatic breast cancer patients. And in those studies, the progression-free survival almost doubled. In the phase 2, it doubled. In the phase 3, it almost doubled. So the PFS with palbociclib and hormone therapy in the first-line setting was 24 months compared to about 14 months in the hormone therapy alone. So based on the approval of palbociclib in the metastatic setting and the very impressive benefit in PFS, we are now looking at palbociclib in the adjuvant setting. So we have 2 trials open at UCSF. One is in patients who've received neoadjuvant treatment. So we want to accrue high-risk patients. So these are patients who have residual disease, significant residual disease after neoadjuvant chemotherapy. So these patients then go to surgery, they get their usual radiation if applicable, and then they get randomized to either palbociclib in combination with their standard hormone therapy or just their standard hormone therapy and placebo. So this study is ongoing. We have a second study looking at palbociclib in the adjuvant setting. This trial does not require neoadjuvant therapy. You could enter after surgery in the adjuvant setting. You actually don't even need chemotherapy. You can enter the study and just get hormone therapy with or without palbociclib. So I'm going to stop there and just summarize, and then we can take questions. But to summarize, endocrine therapy is a highly effective targeted therapy and should be recommended to essentially all hormone receptor positive tumors. The soft and text data support the use of ovarian suppression and aromatase inhibitor in high-risk premenopausal women, so women who got prior chemotherapy and women who are under 35. Tamoxifen alone for 5 years is adequate for low-risk patients. So patients who do not get chemo, low-grade small tumor smooth negative. Extended hormone therapy should be considered in higher-risk patients. The benefit, like I showed you, is statistically significant, but it's small. It's about 2% with 10 years of TAM, over 5 years of TAM. For patients who got 5 years of TAM and are then postmenopausal, I would consider an additional 5 years of aromatase inhibitor based on the MA17 data that showed a 10% increase, or a 10% benefit. There are short and long-term toxicities that may impact adherence and quality of life and survivorship. 2 important ones are AI-related joint pains and vaginal dryness, and now we have some data to at least reassure us and that these are side effects that we can help improve. So duloxetine for AI-related pain and local hormone therapy in the form of E-string, I believe, is likely safe and it certainly improves quality of life for vaginal dryness. But regardless, risk and benefit needs to be discussed and individualized for all patients.
Thank you very much. We have time for some questions now, if you have some questions.
I know this talk focused on breast cancer patients in the adjuvant setting, but for the side effect management stuff that you talked about, the data and information from that, would that also be applicable to the metastatic setting?
You mean the duloxetine?
Yeah.
Yeah, certainly. Yeah, there's no reason to. Yeah, I think patients in the metastatic setting are more heavily pretreated for sure. They've had a number of different treatments, and so we can't say for sure that it would be equally effective, but definitely worth trying.
Is oophorectomy equivalent to pharmacological ovarian suppression? Because we see several patients after the 2 years, often they decided to go for an oophorectomy.
Mm-hmm. In terms of efficacy, nobody has ever looked at that. I think I think the question is, are we adequately suppressing them medically? So there have been some data that have shown that patients on ovarian suppression in AI actually did worse than patients on ovarian suppression plus tamoxifen, and that was related to their BMI. And so the hypothesis is that if we are not adequately suppressing their estrogen, then the AI, for reasons that we discussed, may actually increase their estrogen levels even more and lead to worse outcomes. But if you are adequately suppressing their ovaries, I believe that it's equivalent to surgical menopause, but for sure, surgical menopause is 100%. The other thing with medical ovarian suppression is that you have to check their estradiol levels with some frequency. I do it initially monthly until they're on some sort of steady program, and then every 3 months. So they would need monitoring going forward.
And I have another one quickly. Thank you so much for, I work with young survivors, and the other question is, as trained, has any patient mentioned the high cost of copayment? It's a non-preferred drug, and their insurance now are considering 3 months supply, so the deductible goes times 3 instead of 1, and we see patients, I think it's a $500 cost, and outpatients, they pay up to $200 for 3 months. Have you seen anything that you can help our patients?
I wish. It's been an issue it's been variable with insurance carriers, but I certainly have patients where they just can't afford it. And there are alternatives like Adjuvant or just local estrogen, and there just aren't data there. There is one study, an old study with Adjuvant, where 6 patients, and they did see an increase in systemic estradiol levels, and so I hesitate a little bit more with Adjuvant. But if a patient can't access E-string, it's a difficult situation and a trade-off.
You had touched on tamoxifen for 5 years, and then in the postmenopausal woman that was after that going on an AI. What about tamoxifen for 5 years and then medically suppressing or oophorectomy after the 5 years on a woman, a premenopausal woman? Does that make sense?
Yeah. So in this day, because we now have the soft text data, those patients should be on OSAI even before they finish 5 years of tamoxifen, right? So I think there are probably other reasons that a high-risk patient is still just on tamoxifen alone and then getting to 5 years, and you're making a decision at that time whether or not to medically suppress and do an AI. Because since the soft text data came out, if somebody is high risk, I switched them already. Yeah. But if for some reason they had side effects or for other personal reasons they didn't want to do it for the first 5 years, but they're high risk, I would do whatever it took for them to be able to tolerate an AI after 5 years of tamoxifen.
Is there a question up front?
I was just wondering, since we do see such young women, what is your counseling for their childbearing or fertility pre and or maybe post? Do you guys have a standard?
Right. So I could have done a whole talk on this, and because time. I left it out completely, and I know you guys have a session tomorrow. So it is a standard, right? Well, maybe not you guys, but there is a session tomorrow on fertility. But it's important to refer these patients as early as possible to fertility specialists if they are interested in future childbearing, and even if they're not sure. So we do that immediately in any woman of childbearing age. The ASCO guidelines are to do that, and cryopreservation of oocytes or embryos is considered standard. So if a patient really wants to preserve her fertility, I recommend that they undergo egg harvesting and cryopreservation. There are data using, GnRH analogs like triptorelin and Lupron to preserve ovarian function during chemotherapy, and that data are mixed. There have been some positive studies, some negative, but those studies are looking at amenorrhea, meaning return of menses, not fertility. And I think I would not rely on that data as reassurance that that will preserve fertility. So if a patient is really serious about wanting to preserve fertility, I would recommend that they talk to a fertility specialist and do egg harvesting. Now, there's other issues around that with cost, but from a medical standpoint, that is the most effective form of preservation. And that's true even of hormone therapy alone. So depending on the age, right, like we're recommending, even if they don't get chemo, we're recommending at least 5 years, and if they're younger, maybe longer. So if they're diagnosed even at 37, 36, and they don't harvest, then it's 41, 42. So it's not just the chemo, it's patients who are getting hormone therapy too. And actually, I just finished a study a couple years ago looking at whether or not tamoxifen accelerates menopause. So I think there's a myth out there that tamoxifen induces menopause or accelerates menopause. So we looked at that. We looked at women who did not get chemo, who just got hormone therapy, and looked at their age of menopause. So age of menopause is a surrogate for ovarian reserve. It's not perfect, but it's the best surrogate we have. It's much better than whether or not you get amenorrhea with chemotherapy and when your amenorrhea resolves. So when we looked at premenopausal women who did not get chemo and who got tamoxifen, there was no difference in their age of menopause, their subsequent age of menopause, whether they got tamoxifen or not. So that's not an issue in terms of accelerating menopause. The issue is more that they're going to be on it for 5 years and then they'll be older.
Question or two? We have time. Thank you again. There'll be opportunity at the end.